So it's my pleasure now to invite Tim Kendall, who's come all the way from Edinburgh, to give a talk on the role of pathology in cholangiocarcinoma in the patient's clinical journey.
Okay. Thanks, Shahid, and thanks, Helen, for asking me to talk. I've just, as I was sitting there, just realised that it's probably 2002 was the last time I spoke in a professional capacity to people that were outside of the profession. Since I joined pathology, pathologists almost never get a chance to talk to patients in the public. So it's actually a rare opportunity and quite a privilege. This is the definition of pathology given by the Royal College. So all of the specialties are kind of under the guidance of Royal Colleges, that they set the exams, we pay them to do the exams, and we pay them every year to stay a member of the Royal College, and they tell us what to do. And this is how the Royal College of Pathologists define pathology. Now, my friend and colleague, Max Robinson in Newcastle, he's redefined that. They said the science behind the cure, it's sometimes written, and he thinks pathology is really the art behind the science behind the cure, because a lot of it is us as pathologists, histopathologists, looking at something and saying what we think. So what I wanted to do today, the first part of the talk, is really to explain what that process is and who it involves, because I guess the only interaction you might have with pathology or pathologist is someone saying, one of your clinical doctors who's done a biopsy or done surgery, saying we're waiting for the pathology result. And what does that really mean? For histopathology, it means looking at tissues. So that's normal liver on the right-hand side. That's what I spend my day looking at. You can see there's lots of pink and purple dots. Purple dots are nuclei, pink is everything else, and then there are big spaces that are nicely distributed from one another. That's what the liver looks like. Histopathology is looking at tissue, looking at cells in context, and saying what we think under a microscope, really. And again, this is taken from the Royal College of Pathologists website. The histopathologists make diagnoses and then help after surgery to stage, which defines what treatments are then necessary or useful. It makes it sound like it's just me looking at some slides and that's the result, and then everything goes from there. But that couldn't be further from the truth. Actually, what I do and the results, the report, not a result, the report, the opinion that I put out in an authorised report is the end part of a very long sequence that involves the interactions with and work from a lot of different professionals, all acting as a sort of hidden army that no one will ever see. In fact, I took the first slide out, which was the photograph of the departmental door. It's unmarked. It's just a blue door with a swipe access. So what I did, with permission from my head of department, was follow a specimen around the department. I asked if anyone's photographed in these pictures, they were able to get out of the way if they wanted to. So what you can't see is all the people hiding behind me when I took the photographs. But this is just to show you all the steps that happen that go into generating this report. The first thing that happens when a specimen is removed from a patient, so a biopsy or a surgical specimen, it goes into a pot with formalin. Formalin's a solution of formaldehyde. What that does is we call it fixation. It glues the tissue together. It makes something soft become sort of hard and firm. It means we can do things to it with microtome, with blades, and cut it, and everything is still retained. And that starts the instant it gets put in the pot. The portering services will then bring it to the department, but it has to be booked in. So in Edinburgh, where I work, we have about 80,000 cases a year that come through the histopathology department. There are probably 2 to 3 separate samples per case. So that's, let's say, 200,000 different pots come in. Keeping track of those is one of the most important things. They have to match up, always have to match up with the patient details. And you think, well, that's fundamental. It's absolutely fundamental, but it's not the most trivial task in the world to follow the identifiers all the way through. So every step in this process, things get checked twice. Right? Every single photograph that I'm going to tell you about, every step, things get checked, tries to make sure it's the right thing. But once the specimen's booked in, if it's a big specimen, what we need to do as pathologists is to examine it macroscopically. That means just looking at it. Often we cut things into slices and then look at them to work out what's where. If there's a tumour there, where has it got to? We take samples that show us the relationship between the tumour and the different structures that are important that guide further management. If it's a small biopsy, we don't have to do anything, but the staff in that right-hand picture will place that biopsy into what we call a cassette. It's a small plastic little cage, really. So the small specimens go into the cassette, or if we cut them ourselves, the big specimens go into this little plastic cassette. If I do cut the specimens up myself, that on the left-hand side is the bench where we do that. And you can see there's a microphone hanging down, so we're dictating what we say as we're going, so that there's a report about what we thought at the time. So you end up with tissue in this little plastic case, this little cassette. What we have to do is remove all the water. So we're 70% water as human beings. We need to remove that and replace it with something else. And that process is called processing, appropriately enough. And those machines on the left are where these little plastic baskets of tissue get put through, and they go through a sequence that basically removes all the water and replaces it with alcohols. That process also takes lipid out as well. After the tissue's been processed, we have to move it from the little plastic basket and we have to embed it in wax. And that's the process that's going on the right-hand side. So what the scientists on the right do, they take the tissue out of the basket and then they put molten paraffin wax. And it is paraffin wax as a byproduct of the petrochemical industry. Actually, people have tried using beeswax when we couldn't get paraffin wax, but any wax will actually work. And we're effectively replacing the water that we took out in processing with wax. That means that tissue can then stay there for 100 years, and it will be okay, sitting in a block. The wax is then left to cool, and you end up with tissue embedded in wax. What we need to look at under the microscope is very, very thin slices through the tissue. So they're 3 to 5 microns, so thinner than a human hair, because we have to allow light to shine through it. So it has to be really, really thin. To do that, there's an incredibly technically gifted skill, which is using a microtome, which is a very, very, very sharp blade. You put the wax block, and then you roll the handle, it moves this very sharp blade up and down, and they're taking off very, very thin slices. And those machines on the left-hand side are where that process is happening. You can see there's a black kind of bowl, really, in the foreground. That will contain some water, because you float these very thin slices on the water, and then you put the glass slide underneath and lift it up. So the very, very thin slice of wax and tissue is then nicely mounted on a glass section. So then we have very, very thin slice of tissue on glass. Still can't look at it yet because it's not stained with anything, so we need to stain it. We need to make it go pink and purple, like we saw in that picture that I showed you. The machines on the right are the automated staining machines for hematoxylin and eosin. That's our workhorse stain. It's very old-fashioned. So the hematoxylin is, let me get this the right way around, and I can't remember offhand. One of them is derived from tree bark, and they're at least 100 years old as a stain. In fact, if you showed it to Robert Hooke from 1667, he'd probably understand. It's advanced, and it's not advanced in 300 years. But the machines on the right stain, so we end up with a glass slide with sections of just the tissue stained pink and purple. Then they get a glass cover slip on top, and then the slides and the form that comes with the slides come to me, or come to us as pathologists. So this is the first interaction, if I haven't done anything, with the largest specimen that I have with the tissue. And that's my desk on the left. And that probably sums up what most of what we do. So looking at down a microscope, which is on the right-hand side, the light shines from the bottom up, comes through the tissue because it's so thin, and I look down the eyepieces and say what I think. And then there's the computer on the left, and I'll type my reports, or often we use voice recognition software instead. That's okay, that takes us to a certain point, but sometimes we need to do digital analysis, and that machine on the right, which is actually just next to my microscope, is a digital scanner, so we can scan the sections and do digital analysis if we want. That's coming in, and some pathology departments are now fully digital in their workflows. But sometimes we need to do extra stains. We need to see whether the tumour is expressing a particular marker that is useful to know to guide treatment, or useful for us to know to guide a diagnosis. So we request those stains through our immunohistochemistry department, and that's them on the left-hand side. So they do lots of different staining with lots of different antibodies that we ask for, and then they give us those slides back. The machines on the right are the automating machines that do that special staining. Now, increasingly, and very pertinent for cholangiocarcinoma, is molecular pathology. And my colleague from Southampton, Dr. Matt Evans, is going to talk properly about that later. There's molecular information we need to know about cholangiocarcinoma and many other tumours now as well. So we request the test, and then tissues cut from that same block, and then DNA can be extracted, which is what's happening on the left, or RNA can be extracted, so that the messages hidden in that tissue can be taken out, and then they can be analysed to see whether there are particular genetic abnormalities that define suitability for targeted treatment. And that's one of the machines on the right where that analysis happens in our laboratory. Often, these techniques generate lots and lots of data, so quite highly complex genetic data or gene expression data, and it needs a lot of analysis by highly trained postdoctoral scientists in molecular pathology labs, and that's who you can see on the left. So that in Edinburgh is rare in that we have our molecular pathologists embedded in the same department. They're just across the corridor from me. So they generate the additional information that is useful to add into that report. But the report still needs to go out, and sometimes it needs to be typed, and then the meetings that organise discussion of the cases need to have coordination at administrative level. So the picture on the right is our administrative staff room. All of the people are necessary to get that result out to allow management. If any one stage fails, it all fails. So we're all part of this kind of hidden army together. I'm going to finish talking about the research side. I know it's kind of backwards from the title that I was given. And it's going to start off with acknowledging a difficult past. So about 20 years ago, there was the Alderhay organ retention scandal. So what was happening is that mostly pathologists were retaining organs and tissues from postmortems. But it revealed a more systematic retention without any form of consent or any form of authorization that had happened. It was very common, and it's not, it was a different time. It was wrong then, and it's wrong now. And obviously, as a consequence, barriers came down. He said, well, this has to understandably stop, and there was a public outcry. And it led to a change in academic pathology, actually. There was people decided they'd changed their practice, or some people retired, some people stopped being academics. And understandably, the response to that was, okay, this has to stop, and it did. Now, the piece on the right, which is co-written by Professor Sir Lord Winston, isn't he, that you'll know, written at the time when the changes were being made or being implemented, raised those points that you can read on the right-hand side there. So those authors foresaw that the response to that malpractice, which is what it was, could potentially introduce barriers. There was a possibility of it leading to a collaborative, transparent process, but it could introduce barriers. That was what they feared would happen. And they said at the time, there is evidence that some bodies are doing that. And they were right. That's largely what's happened. Now, my view, and it's only my view, is that the tissue that we hold, organisations, the NHS, we hold, contains all the information about the disease. We just have to kind of get at it. But it's not good enough for me to say, oh, well, we can just start using it again. If you're in a clinical trial, patients in a clinical trial, That's a consented process. We're happy with that. But as Shahid mentioned, the trial population isn't necessarily representative of the United Kingdom as a whole, just because of the way patients are recruited or the way the centres are. What that means is, when a treatment ends up coming through after a trial, it might not be the most suitable for all these patients that are underrepresented in that trial population. So they're missing out on the trial, and they're also being then subject to, but experiencing treatments that are not necessarily the most appropriate for them. The clinical archive will hold everyone's tissue. Now, this is me asking you, what I want to know is what we should be doing. It was paternalistic, even at best, that we, the medical profession, pathologists, were just using that tissue. That was a time when research was done on patients or for patients. That's gone. Now, research is with patients and by patients. So what I want to know, and I'm leading a process through the Pathological Society, is to hear from as wide and as genuinely representative group of patients, patient group representatives and the public, to know whether you think we should be almost obliged to use the tissue that we have, the information that we have available to try and advance understanding. Similar processes are happening with data. Tissue and data go together. As we've mentioned, and we'll be hearing from Matt, there's now more information in that tissue that we can get at with molecular techniques. So I want to find out whether there is an appetite, whether there's an army of people behind saying you should be trying to change to allow transparent, patient-directed, completely regulated research, but using that clinical archive. So that's what I'm trying to do. It might fail, but I think it's too important not to try, so I'm going to. Thank you.